My real interest in this stemmed from my experience with the robot, and what the robot gives you a lot of advantages in terms of a bone cutting device, but there are a tremendous amount of disadvantages with the robot. I was having, and this is true for any navigation, and we talked about this before, you have the problems of pin placement. You have fractures around pins. You have overall OR setup. So if you want to talk about massive changes in efficiency from taking almost an hour to 2 hours of just surgical setup with a robot, you are eliminating all those steps with this pre-navigated device. And really, the trend that Conformis is really going for is completely pre-navigated, pinless conforming jigs, which I think is a revolution in orthopedics. And its potential applications for medial, lateral, partial knee, duo knee, tricompartmental knee. You can even extend it to osteotomy. When you have true conforming cutting devices, it's a powerful tool, an extremely powerful tool that's extremely accurate. And then we're not even talking about adding the accuracy, the advantages of the kinematics of patient-specific implants. Again, I want to make a point to differentiate Conformis with all the other companies. All the other companies have patient-specific jigs, but off-the-shelf implants. This is the only company that has patient-specific jigs and patient-specific implants. So really, I think, a revolution in orthopedics. So we're going to go over, first there's a cartilage removal process. There's the balancing process, which Amar was talking about, which is the I-chip. And basically, you're assessing the flexion and extension gap, and that will then dictate your level of tibial resection. And then we talk about the tibial cuts, the femoral preparation, tibial preparation, and then cementation. So again, just to review, we kind of talked about this, is that you get this kind of template of what bone you want to remove so this can fit on like a glove. And that's the whole concept. When these fit on like a glove, it's a true conforming jig. And this was a trial and error process because basically we wanted to show the surgeons, you make it really almost idiot-proof of what bone you should quickly excise. And really, just removing this bone is all the femoral preparation you do. You take a rongeur and you go boom, 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 and you're almost ready to put the femoral jig on. So let's just go through the technique. This is kind of what you have. It's very, very simple. First, you want to do cartilage removal. This is probably the most tedious portions of the case. You've got to take a curette and just excise the cartilage because this is truly a resurfacing. It's truly a bone-preserving procedure. So with a combination of a knife and a curette, you want to scrape off whatever cartilage you have there. You don't have that much cartilage there because it's an arthritic knee. And you kind of scoop it out. There are various different types of curettes you can use. Now using the balancing chip, which I was telling you before, and you want to put that balancing chip both in flexion, as you see right now, as well as an extension. And there are multiple different balancing chips to give you that proper tension of the MCL. And this is your kinematic feedback. This is balancing your flexion and extension gaps. It will also give you a rough estimate of your coronal alignment, but just to triple check it, they've also included a rod. So you're getting your coronal alignment with the chip, and you're getting a double feedback with the rod. You drill a couple of drill holes, and then you do a sagittal cut. As Amar was saying, you tickle the ACL. A couple one of these we've done, we didn't get close enough to the ACL, so we have to recut that. You really want to get almost to the level of the spine. Then you cut the tibia. As you know, this is true for any kind of fixed bearing uni. And then you're done with the tibia, and now you go to the femur. Your femoral jig is based off your tibial cut. It's a very Ranawat concept. It's all tibia based, and you're going from it's a parallel tibial cut technique. So your tibia reference, and that's your femoral cut. Reference off the tibia. So it's balance and flexion. You make a drill, you make your lug hole drills there, and you secure it, and now you do your only cut on the femur. This is the only bone you're taking on the femur, and that's about a wafer of bone, maybe a millimeter or two. So you're really doing a lot of femoral preservation, truly femoral resurfacing. Your final tibial preparation are just some drill holes, and this is, to me, critical because, to me, the failure of unis is in fixation. and you really want to maximize your cement penetration into that tibia. And unlike other implants, when you have a good cortical fit, you're not really worried about subsidence. And then cementing the implants, I think, is a very critical part, and you can't underestimate how important that is. And this is actually an example of a lateral uni, but you can see that good cement penetration. You see the good exactly lining up to the cortex. And as I say, very close to the spine. Most a lateral uni is actually, I would say, even a much harder procedure than a medial uni. So these are the kind of features you want to see: is complete femoral coverage, complete tibial coverage, a very conforming femur, patient-specific in terms of you're not hitting the ACL, but you're coming very close, and very minimal bone resection. So the concept is that you're going to get consistent x-rays with avoiding all the hassles of pin placement and of navigation or robotics, whether you want to do a lateral, whether you want to do a medial, whether you want to do a duo. We're slowly collecting some data. This was data, before Amar and I kind of helped them out. And basically, as you would expect, they have significant improvement in their functional scores and knee society scores. But, what you really want to say is that it's an easy and reproducible operation, 100% cortical contact, and the preoperative assessment is really consistent with the intraoperative assessment. This is another study showing that the axial alignment was significantly improved to almost exactly where you want to be. These are navigation type numbers. This truly is a pre-navigate concept. Same thing with a tibial implant fit within a 0.5 millimeter. Tibial slope, roughly what you want. 4.6 was the plan. 4.5 was what you had. And minimal bony resection on the femur. So basically, you're not really doing any compromise in terms of patient fit. It's a true resurfacing concept, and it theoretically could be an early intervention for the early arthritic in terms of bone preservation. So we kind of talked about this before, but in conclusion, the advantages of this to me is it's pre-navigation, it's OR efficient, and it's patient-specific, where you get the maximization of the implants. So if you're somebody like me who's fascinated in maximizing the kinematic function of the knee while preserving the ACL and PCL and then maximizing alignment position, this is something I think that's really interesting. And then also your facilities like it, because your OR time is and your cleanup time is about 5 minutes. Thank you.